Welcome to the 8th seminar in our C6 seminar series. My name is Kate Robinson. I'm your moderator, and I'm a project director with Family Voices. I'm very excited to be here today. About 7.5 years ago, I had a 2.5-year-old and had a child who was born medically complex. And in the past 7.5 years, have spent many months in pediatric hospitals and had the very good fortune to experience real clinical family partnership with Dr. Rahel Burhani here at Dell Children's Hospital in Austin. And it wasn't until I started really trying to affect sort of systems change and work on systems partnership that I found Family Voices and was really happy to do so. So again, just really excited to welcome everyone here today and be a part of this wonderful seminar series. So this seminar series is focused on the clinical care of children with neurodisability and medical complexity. The C6 seminar series is collaborative conversations with families to advance the clinical care of children with medical complexities and disabilities. And it's a 10-part seminar series that's supported by the Lucille Packard Foundation for Children's Health in partnership with SickKids and Family Voices. We're excited to have you all join us today and look forward to your participation and engagement throughout the seminar. Today's seminar will focus on sleep. We want to acknowledge that each healthcare encounter is unique, be it brief or lengthy, and that many of the topics in this series are difficult to address by virtue of the fact that we're addressing gaps in the research, and we can't cover the breadth of the topic, but we aim to at least highlight the cooperative need and value of partnership. A few quick reminders for you. Please remember to submit your questions and comments in the webinar Q&A, not in the chat, but in the Q&A. You can submit any questions that you have or comments for the panelists. Once we've concluded the presentations, we'll move on to the panel discussion, and we'll try to get as many of the questions and comments as we can. Following the seminar, you'll be asked to complete an evaluation survey. You'll need to complete this evaluation by Monday, April 25th in order to claim CME credits for today's seminar. That's Monday, April 25th to complete the application for CME credits. And you'll receive details on how to claim your credits in your email. Based on the rich discussion and high volume of questions and feedback from attendees in previous seminars, we've added 30 minutes to the conversation. So all attendees are invited to stay for a little coffee chat from 2 to 2:30 Eastern. If you can't stay, this cafe sort of Q&A portion is included in the recording. So our aim is to create a seminar series that's a supportive forum and safe place for important discussions that ultimately help improve clinical care. We've partnered with families for this series because their participation is essential to improve clinical care. Families are our clinical partners in care 24 hours a day, 7 days a week, and their experiences and perspectives matter a lot. However, by virtue of the forum being large and virtual and the nature of the discussions, which involve lived examples that may resurface a variety of reactions, we understand that these conversations may be difficult. If anyone needs support after attending the sessions, we invite you to reach out. The links will be shared with you in the chat. We have a link for physicians or clinicians, and also a link for parents and families. And I just want to give a little bit of a trigger warning real quick. I'm about to introduce Kate Holler, and she's going to share some of what her wonderful daughter goes through with her rare disorder, and she will share some pictures as well. And I want to thank Kate for her courage in sharing with us very clearly and comprehensively kind of about her daughter's condition, and so I'm very excited to introduce both family leaders, Kate Holler and Sarah Perkins, today. So first, let's start with Kate. Oh, I do want to say too, just in terms of that trigger warning, just do what you need to do to take care of yourself. It will be talking about, just difficult things. And like I said, showing some pictures. So do what you need to do to take care. Kate Holler is a rare disease advocate and a mother, a caregiver to her 7-year-old daughter, Rowan. Rowan lives with a rare genetic disorder called recessive dystrophic epidermolysis bullosa. I did practice this, epidermolysis bullosa. Kate says it so much better, but otherwise known as EB. Kate is passionate about promoting EB awareness and works to raise funds for research for a cure. She's also served as a family advocate for Dell Children's Medical Center and the Children's Hospital Association. So Kate, can you share a little of your experience in raising a child with medical complexity and sleep, and maybe a bit about what you see as implications for change or improvement?
Yeah, hi. I'm really happy that and thankful for you for inviting me to speak, Kate, and to Family Voices. So yeah, I'm Kate. I live outside of Austin, Texas, with my husband and my 2 kids. I have a 6-month-old, Celine, and I have a there we are. Celine is not yet born in that photo. And then I have a 7-year-old named Rowan. And Rowan, Kate, you did an excellent job. It's hard to say. She has a rare genetic disorder called recessive dystrophic epidermolysis bullosa. And it took me a long time to be able to say that properly. So basically in Rowan's disorder, it's a rare genetic connective tissue disorder, and her body basically just doesn't produce the glue that holds her skin to her body. The protein, her body cannot produce it. It's called collagen 7. And so things that would cause friction or trauma to the skin, like falls or bumping into things, even like seams on clothing, chewing food, swallowing food, can cause her skin to blister or shear away, causing wounds like 2nd-degree burns. And that's externally on the outside of her skin, but then internally as well, because it also affects her mouth, her esophagus, and her GI tract. And I would say she definitely, her condition causes an increased need for sleep at night. We're definitely not the family that's like, oh, it's okay, we'll stay out late, she'll do fine tomorrow, or at least it'll be, it might be a little bit difficult, but she'll do okay. We really emphasize getting enough sleep for Rowan, because I can tell it really makes a difference in her day the next day. Her disorder, she has increased need for wound healing, and just having rest in general. So it's super important for her. We notice that if she doesn't get enough sleep, that she can have difficulty even walking longer distances, or even things such as like writing for longer periods of time. Her hands will get tired, things like that. But I would say like the challenges that she experiences with sleep are definitely very multifaceted. And they include areas like pain, itch, eye problems, eye issues, stress, and anxiety. And so in order to kind of properly explain her condition, which is very rare, and I understand most clinicians can go their entire career without experiencing it. I just wanted to show a few pictures of what wounds look like for her, or what the actual symptoms of having her condition look like, as far as it relates to the wounds that she has on her skin, which of course are painful, like 2nd-degree burns. And depending on how many wounds she has, this definitely affects her sleep. I mean, if you can imagine having wounds like this, and this is just a small, showing of some that are very typical for her, that if you have wounds like this and they're multiple over different areas of the body, that at night, it would be very difficult for you to be able to sleep if this was happening to you. So we definitely notice that pain is an aspect of her sleep, and if she has more pain than she can tolerate, she doesn't sleep well. And we'll need to control her pain with pain medications in those instances. Itching is also a main factor for her. Something about her genetic condition, whether she has wounds present or not, can cause her skin to be intensely itchy. And so she will just be awake or half asleep, just scratching her skin. And that's not usually a big problem for most people, except for when Rowan scratches her skin, she can scratch her skin completely off. And then she might be scratching wounds that are already present, and that's causing delayed wound healing. And it's just kind of a snowball effect from there. The same issues with her skin also affect the surface of her eyes. So she'll rub her eyes because they're itching. And then she can actually have the surface of her eyeball blister or cause like a corneal abrasion, which is very painful. That's also a main factor in her sleep. And then I would also just say the stress and anxiety of having chronic illness is a huge factor for her. We notice that when she's having difficulty with sleep, she's kind of, and this was recent, it was really like the picture of non-restful sleep was if you saw her sleeping. She was scratching her skin. She was waking up in the middle of the night crying because she was having pain. Maybe she was scratching something that was painful, or a wound was just hurting her, even just laying down, teeth grinding, waking up with nightmares. If you can imagine having wounds like this happening to you on a daily basis and not be able to stop it, it's the type of things that don't happen to many people, except for maybe you have an accident and it happens maybe once or twice in your lifetime. But for Rowan, this is like an everyday occurrence. Kind of terrible things can happen to her and painful things. So nightmares are another part of the issue for her. So I think really from our perspective, when we're having a difficult time with Rowan's sleep, it's almost hard to tell who to contact because there's so many specialties that her problems with pain are kind of intertwined with because of her complex illness. So I think the last time when she was having difficulty with pain, I really delayed maybe asking for help because I wasn't sure who to ask, because really the issues she was having kind of encompassed all these different areas, like with our pediatrician, but then also probably with her dermatologist, but also probably with palliative care, and then also probably with wound care, her psychologist. And so I would just say that for us, what's really important is this multidisciplinary care, and being able to speak with ideally multiple specialists at one time is the best scenario for us, and just kind of brainstorming that way, because it's really never just one thing, never just one specialty that we need to solve a problem like Rowan sleep with. I think we used it was probably 6 different specialists, that there was different things going on within their specialties when she was having difficulty with sleep this most recent time, a couple months ago.
Thank you so much, Kate. I'd now like to introduce Sarah Perkins. Sarah has spent her life navigating the healthcare system as a patient. As a result, she's seen the benefits of family and professional partnerships firsthand. She is currently a family leader for Boston Children's Hospital. She has a Master of Arts in Pastoral Studies from Catholic Theological Union in Chicago, and she holds 13 U.S. Masters swimming, top 10 times as a relay swimmer. Sarah, can you share a little of your experience with sleep and maybe what you see as implications for change?
Yeah, sure. So if I think about if you want to call it my sleep history, I can kind of put it in 2 categories. Trouble with sleep caused by spasticity, because I have cerebral palsy, and trouble with sleep just because of regular insomnia, stress, anxiety, some of the things that Kate has already addressed. Having CP, I'm very familiar with various types of night braces and splints that are used to help my spasticity or, different tight muscles. I have a love-hate relationship with them, as most of my friends with CP also do. A trade-off of wearing night splints all day, or all night, I should say, is it's hard to sleep. So you get into the balance of, do I wear this all night? And if you think about, if you go through a normal stretching routine, my leg is constantly being in that state of being stretched. So that's hard to sleep through. Even if it's not very painful, just the fact that it's constant makes it hard to sleep. So often it's a trade-off of wearing night braces and being able to sleep. It's not very common, or it hasn't been, that I've been asked about my sleep and have I been sleeping. It's more of an issue of, am I wearing my night braces? Am I wearing my night splints? Do I have the right positioning to decrease my tone and spasticity? The emphasis hasn't been on quality of sleep. If I bring up the fact that I don't wear my night braces, and I say, then I can't sleep. The answer I usually will get back then is, well, you just need to wear them while you're sleeping. So it's kind of a catch-22. I'll try and wear them, but it depends what mood I'm in usually. There was one time that sticks out to me that I was actually asked about insomnia, or was I was having trouble sleeping, I think was the specific question. And the physiatrist was like, oh, sounds like you have a bout of insomnia. Well, you're not going to sleep a lot if you don't move around enough during the day, which I understood. But at the same time, I was at the point in my life where I was learning to make my own decisions, medical decisions, totally by myself. It was like, you're an adult now, you need to take control of all of everything that comes along with being you. And the follow-up to I need to move around more was, oh, and here's a prescription for, I think it was a pretty heavy sedative. At that age that I was, and I want to say I was maybe late teens, early 20s, I was going to go for the quick fix. I was going to go for the sedative. I wasn't going to worry about moving around all day because it wasn't something the rest of my peers had to deal with. So more education around and more interdisciplinary things of what could have helped me sleep better to balance the night braces. Was I moving around a lot during the day? Was I not moving enough? There needed to be more of a balance there than, here's a prescription for a narcotic, because I'm just going to go with a narcotic. I'm just going to go with the easiest thing that's out there. I know that's not the case for everybody, but that was the case for me. And at that point, I think I was on at least 4 different medications before that narcotic was introduced. So then I got into polypharmacy route, and the side effects had side effects, which then also affected my sleep. I've been able to address a lot of my sleep issues myself, mostly through the athlete related books. There's a lot of literature coming out now. As Kate said in my intro, I am a swimmer. So if I think of myself more as an athlete than a patient, that helps, or I should say that's helped me most, because now there's more of an emphasis being put on sleep is a tool in the toolbox to help you perform better. And that's how I got those top 10 times, or I would like to think, the fact that I got a good night's sleep or several nights of sleep ahead of big races helped me reach those top 10 times. So yeah, I think what helps is what Kate Holler said earlier, of there needs to be more of one person can't just address the sleep. What's the underlying issue of why are you not sleeping? Is there something that's causing you pain? Then that needs to be addressed, and then maybe you'll sleep. If you address the pain and you're still not sleeping, then look into the sleep part.
Thank you so much, Sarah. So first, before we move on, I just want to apologize for the issue with logging in. That hasn't happened before. We are recording this, so you will receive an email with the recording of the presentation. So again, apologies for that. Thank you, Sarah and Kate, so much for sharing with us. Our didactic speakers for today are Dr. Caroline Okorie and Dr. Shelly Weiss, and their presentation will be on sleep. Obviously, Dr. Okorie is a board certified pediatric pulmonologist, sleep medicine and general pediatrics doctor, and joined the Division of Pediatric Pulmonary, Asthma and Sleep Medicine in 2018. She obtained her medical degree and master's in public health at the University of Arizona before going on to a residency and chief residency in pediatrics at Oregon Health and Science University. She completed her fellowship training in both pediatric pulmonary medicine and sleep medicine at Stanford University. She has a passion for medical education and serves as an associate program director for the pediatric residency program at Stanford. And Dr. Weiss is a pediatric neurologist with expertise in epilepsy and sleep neurology. Dr. Weiss has held national leadership positions in sleep medicine, including past president of the Canadian Sleep Society. She has national education leadership, including her position as the Area of Focus Competence AFC Vice Chair in Sleep Disorder Medicine for the RCPSC. Her research is focused on the medical and surgical treatment of drug refractory epilepsy in children and interventions to improve sleep in children who are typically developing and have neurodevelopmental disabilities. A reminder that you may submit questions in the chat questions in the Q&A for the discussion. With that, I'm honored to turn it over to Dr. Okorie and Dr. Weiss for their presentation.
Thank you so much for that introduction. And so Dr. Weiss will be controlling the slides, so I'll just be asking her to change between. So next slide, please. Just wanted to say both Dr. Weiss and I have no financial disclosures or conflicts of interest to report. And this is just a reminder about how to get your CME credit. And next slide. So I just want to say we're very grateful for the perspective from Kate and Sarah. Thank you so much. It's so helpful to hear their perspective. And Dr. Weiss and I will really kind of cover some overlapping topics in sleep medicine, but it's such a broad topic that we obviously cannot address it all. But in the time, we will hopefully highlight some key points that will help in your practice. And I think Kate and Sarah's stories just really highlight the need for comprehensive, individualized care by any team. So I think it's important for all of us, even those of us who aren't sleep specialists, to have some knowledge of sleep, just so we know to kind of address it, to think about it, and to help patients overall with their quality of life. So the objectives of this talk will include talking about the importance of sleep, some of the consequences of sleep, especially for children with medical complexity. And we'll also talk a little bit about sleep disorder breathing. That'll be the part that I focus on. And then Dr. Weiss will talk about looking at insomnia and some of the pharmacological and non-pharmacological treatments with it. We'll also talk about some emerging therapies too. Sorry, next slide. So just very briefly, what is sleep? We used to think it was just the lack of wakefulness, but we've actually learned it's a very complex state of being that actually is made up of several different stages of sleep. So this is just kind of showing how all of us actually cycle through different stages of sleep throughout the night or throughout the time of sleeping. So we have REM sleep, which is when we tend to dream and our body tends to be paralyzed or relaxed or doesn't really move as much, so we don't act out our dreams. We have N1, which is a transitional time between wake and sleep. And then N2, which is light sleep, and then N3, which is deep sleep. We have a little more deep sleep in the start of the night, a little more REM sleep at the end of the night. As we get older, we get a little bit of less deep sleep as we go. So it's really a very dynamic process, and I just wanted to highlight that here. So why do we sleep? So we think sleep is thought to be restorative. So it's a time to build muscle, time to build bone. It activates your immune system. It consolidates your learning and your memories. When we don't have sleep, I think a lot of us know what that feels like. And it's harder to learn, harder to concentrate. It can affect your mood. There's increased risk of depression and anxiety when you don't sleep well. Decreases your immune function and really can affect your whole quality of life, as Kate and Sarah kind of alluded to. And I think even more urgently is actually increase your risk of suicidality. So here are some examples of pediatric sleep disordered breathing, which is just an umbrella term that talks about just you have issues with breathing when you sleep. So it could be obstructive sleep apnea, which is the most commonly known. That's where you have some obstruction in your upper airway. You're trying to breathe, but you have something partially or fully obstructing. You can have central sleep apnea, which is just a pause in your breathing. And there's some conditions that actually cause the signal to the brain and the brainstem not to go and cause kids to actually pause in their breathing. Hypoventilation just means you're not able to breathe deep enough and really get that carbon dioxide out that you want to. And there's definitely several conditions. I see a lot of patients. I think actually Dr. Weiss and I both see patients with neuromuscular weakness and can have hypoventilation, and then hypoxemia or low oxygen levels. So these are all examples. So the symptoms and the consequences of sleep disordered breathing include snoring, restless sleep, night sweats, teeth grinding, even sleepwalking, being irritable during the day. It can even affect your growth. Growth hormone tends to be actually secreted during our deep sleep. So if you actually are deficient in deep sleep, you can be deficient in growth hormone. You can have consequences such as impaired cognitive development, like we've talked about, the mood issues. In adults, we see more of heart attacks, high blood pressure. In my population with lung disease, sometimes you can see pulmonary hypertension. For patients with diabetes, it can be even harder to control your diabetes. You have more insulin resistance. And overall, you have increased healthcare utilization. So for kids with complex medical complexity, in terms of sleep disorder breathing specifically, I think there's, Sarah mentioned spasticity. That can, of course, cause pain, but actually can also cause sleep disorder breathing in the upper airway. You can have also your orofacial structure, elevated BMI, neuromuscular weakness I talked about, or having neurological abnormality, all place these kids at more risk for sleep disorder breathing. So I'm sure many of you have heard of a sleep study. So why do a sleep study, especially in this population? So anytime you're worried about sleep disorder breathing, your patient's at risk for it, it's actually recommended for most patients that if they are at risk for sleep disorder breathing, they should have a sleep study just to see how things are and to track, because some of these symptoms can be very subtle and you don't see it until they're more severe. For kids with tracheostomy, it's a way to actually determine if they're ready to have that removed. For non-respiratory things, it could be if you're looking for seizures, looking for movement disorders, or looking for things like narcolepsy. So how to prepare for a sleep study for any pediatric patient, especially those who have sensory issues, developmental issues. It's really important to just prepare, anticipate, and have a shared decision-making with the family. So I never just tell families just go and, have at it, but I usually actually show a little video. I show them what to expect. I try to actually really talk to the kid directly about the sleep study and what they should expect. Tell them to bring transitional items like loveys, stuffed animals, their favorite pajamas, etc. So I think really preparing your kids for the sleep study helps increase the success for it. And you can even consider desensitization interventions at home, such as practice with stickers, maybe a nasal cannula in your nose, just to try to help it not be quite so frightening. So the treatment for sleep disorder breathing, I'm going to just touch on a few here. I know some of them are more familiar and some are probably less so, but surgery, adenotonsillectomy, removing the tonsils and the adenoids, medication therapy, which I'll talk about, different orthodontia to help kind of open up the airway, CPAP, which is very common, weight loss if appropriate, and then different kind of emerging therapies that I'll talk about too. So I just want to take a quick word on adenotonsillectomy. It's effective when indicated, but watchful waiting is a reasonable approach. And there's been a lot of studies that show that, especially children with mild sleep apnea, sometimes it can resolve without surgery. And then as for some patients who are at high risk for surgery for various reasons, watching and waiting can be reasonable, and thinking about some of these alternative therapies. So I just wanted to highlight the importance of promoting nasal breathing when possible. So there's a lot of studies here, just two here that highlight that when you actually have mouth breathing, it can actually contribute to rotational displacement of the maxilla, palate, and the mandibular body of the mandibular ramus. So it's very interesting how just in not being able to breathe through your nose can affect the whole structure of one's face. Even after getting adenotonsillectomy, if you still don't encourage nasal breathing, we find that kids actually are still at high risk for sleep apnea. And so a couple of things to address nasal breathing. So medical management can be an option. Intranasal steroids, just spraying to reduce the inflammation, usually in the turbinates and sometimes in the adenoids, has actually been found to be modestly effective in mild OSA. Most of these studies are short-term studies. When combining the intranasal steroid with montelukast, it's actually thought to be more effective. Montelukast has been found to, it helps shrink the lymphoid tissues of tonsils and the adenoids. Recently, though, the FDA has required a black box warning with montelukast. It's been implicated in having more neuropsychiatric side effects. So it's one that I know many of my colleagues and I, we used to use more, but we use less just because, especially in kids who are already having trouble with sensory or emotional issues, I think it's one that we're more cautious about. But just wanted to mention that sometimes just shrinking the tissues in the nose can actually help breathing. Another one to think about is orthodontia. So I think more and more orthodontists and dentists are being more aware of things like maxillary expansion. So there is some evidence to show, so maxillary expansion is where you take a child who is still growing and you expand the hard palate, which does reduce teeth crowding. It also expands the nasal base and improves nasal breathing. When they look at a meta-analysis, it shows that there is a reduction in AHI, it helps your oxygenation. Most of the studies are short-term, within 3 years of follow-up. We still need some more data about long-term follow-up past 3 years. And I just want a quick note about myofunctional therapy. This is specific exercises that essentially targets the facial muscles of speaking, chewing, and swallowing, and specifically can help actually encourage nasal breathing. So studies have actually shown it to be effective in even reducing AHI in adults and children. It reduces sleepiness, reduces snoring, and it can improve oxygen saturations. Of course, long-term studies are needed, and it's not always easy to find a myofunctional therapist you can work with, and at least in the States, we have a hard time getting covered by insurance, but it's nice because it's another therapy that can really work for a lot of families. So what about CPAP and PAP? So just briefly, PAP it works when it works. So it's great if you have a patient who has obesity, craniofacial abnormalities, they've had surgery, but they still have OSA. So CPAP is a great option for them too, or they have a primary pulmonary condition and need support for other reasons. Issues to consider, of course, desensitization is really important, especially in kids with sensory issues, and a lot of complex kids or kids with complex medical issues who have sensory issues. But it's really important to be careful about mid-face protrusion. So what that is as the face is trying to grow, if you put some even gentle pressure on their face, it actually can affect their mid-face and actually not allow it to grow forward, which then can actually increase their risk of having a narrow airway and sleep apnea, as well as cosmetically. I think a lot of kids get very sensitive about it as well. So that's something where we have to be really cautious about and monitor, and usually working with an orthodontist to see how you can counter that will be important. And then adherence. Same adults and children have the same issues sometimes with CPAP. It's interesting because when we look at adherence, increased adherence is actually associated with non-Latinx white race, younger age, higher baseline AHI, so the more severe the sleep apnea, or actually patients with neurodevelopmental disorders actually do a little bit better. Risk for poor adherence is increased if you are younger than 6 years of age or older than 15. And if the settings aren't right, the mask fit isn't right in the beginning. It's kind of like if you don't get it right in the very start, you have more risk of it not working. So really having clear desensitization protocols and working with close follow-up is important in the beginning. And I just want to make a quick note about auto CPAP or auto PAP. This is a therapy where basically the machine, you kind of set parameters and the machine will automatically kind of adjust the settings at home based on an algorithm. And this has been tested in children, and it actually is found to be an effective therapy for the right kid, and actually can reduce delay in care and allow more desensitization strategies at home. High flow nasal cannula. So we're talking a little more, it's like some of these emerging therapies. So high flow nasal cannula, which is kind of what it sounds like. You have a nasal cannula similar to an oxygen cannula, and it just goes at a much higher flow. So this has been studied in kids who can't tolerate CPAP. This would actually offer some benefit. So there's very small retrospective reviews out there, but they do show that you can actually treat from mild all the way to severe obstructive sleep apnea with high flow nasal cannula, and it can serve as a bridge to surgery for some children. Again, more data and more studies are needed, especially in kids who have hypoventilation, but it's another thing to consider. And then I wanted another emerging therapy is the hypoglossal nerve stimulator. There's been studies of specifically in kids with Down syndrome. So there's a case series that's been ongoing for a few years. It involves 20 children with Down syndrome, ages 10 to 21. and they have generally severe sleep apnea, and they've failed CPAP therapy. It's been found, so what it is, oh, I actually should go back and see what it is. So what the hypoglossal nerve stimulator is as you can see from this picture, you have this small device that's implanted in the chest. It has one of the sensors goes into the muscles within the lung or within the chest. So when you take a breath in, it can tell that the muscle is kind of expanding. And then it has another lead that goes up to, oh, thank you, Dr. Weiss, to the tongue. And so when it senses, oh, we're taking a breath in, it actually causes the tongue to move forward and get out of the way, essentially get out of the airway. And so throughout the night, with every breath in, the tongue is moving forward. And so they've done this, and it's already approved in adults, and it's already a therapy that's being used, and it's now been tested in kids with Down syndrome. And it's actually found to be relatively effective, really well tolerated, and has improved quality of life in these patients. So it still appears to be a reasonable option for patients with severe OSA who can't tolerate PAP therapy, but further studies continue. So this is another emerging therapy. And then last is medication treatment for sleep apnea. And so I know I talked about the nose spray to actually shrink the tissues, but this is actually medication to change the muscle structure. So there's a combined medication, which is atomoxetine, which is a norepinephrine reuptake inhibitor, and oxybutynin, which is an antimuscarinic. So this actually increases the genioglossus muscle responsiveness, which is your upper airway dilator muscle. So this is tested in adults, and it has reduced the severity of sleep apnea by 63%. And the long-term study is about 1 year out and found to still be effective. So brand new therapy among adults. And there's actually new trials that are just starting up for kids with Down syndrome, ages 6 to 17, and they are going to see how this works in that population as well. So some new exciting therapies that are coming out that can hopefully help our children who especially struggle to tolerate CPAP therapy. And I will leave it to now Dr. Weiss. Thank you.
Thank you very much. On behalf of the 140 participants, I will thank you for that excellent presentation. Hold on, I'm going to now talk about insomnia. You heard about obstructive sleep apnea, their sleep disorder, breathing problems in like 12 minutes. And now we're going to talk about insomnia, which is very frequently seen in children with medical complexity, again, in about 12 or 13 minutes. So we'll take questions after. I'm going to summarize some of the non-pharmacologic and pharmacologic treatments. And I'm really going to stress, as you heard so eloquently by Kate and Sarah, the need for multidisciplinary, comprehensive, and an individualized approach when you're thinking about these children with insomnia. Thinking about children with insomnia, sorry. Just going to go to the next one. So first, just to make sure everyone knows what the definition of insomnia is. Insomnia is when a person resists bedtime, so has trouble falling asleep, wakes up at night, wakes up too early in the morning. And as you know, you can have any combination of these problems. Sometimes it's just one, but it could be actually all three. Insomnia, when it's chronic, when it lasts more than 3 months, is called a chronic insomnia disorder, which is the most common disorder for children with medical complexity, as it includes, as I said, falling asleep, staying asleep, or early awakening. There has to be a daytime consequence. So the person has to be tired, not doing well in school, having other issues during the day. There has to be adequate opportunity for sleep, and it has to be frequent and chronic and not explained by another sleep-wake disorder, medical condition, or a mental health disorder. That's the International Classification of Sleep Disorder definition of chronic insomnia. So how common is pediatric insomnia? When you ask parents of typically developing children, these are from many different surveys done in primary care physician offices, even when the parent is not at the office because of an issue of sleep, but just when you ask parents, about 30% of parents of typically developing children will endorse that their children don't sleep well. About 85% or more of parents of children with neurodevelopmental disabilities will meet the criteria for insomnia most often if they have a sleep disorder. And we don't actually have good data on children with medical complexities because it's includes such a large number of different disorders, but probably there's similar prevalence. And the important thing about insomnia is you might hear as a parent or you as a physician that someone tells a parent, well, don't worry, your child will start sleeping well. Like, you don't have to worry about their insomnia, but truthfully, it often lasts into adolescence and adulthood. And there are obviously many factors about insomnia in children with medical complexity. So when we think of biologic factors, depending on the child's disorder, there can be neurochemical, hormonal issues, circadian clock factors, sensory differences, such as children with autism may like heavy blankets or light blankets or no blankets. You heard about anxiety and depression influencing sleep. And then the medical problems, we heard about sleep apnea, but also when children have trouble with vision, hearing, seizures, reflux, spasticity, which we heard from Sarah, or medications, those can also affect sleep. And then there's a lot of behavioral issues, which is what I'm going to concentrate on. Inconsistent sleep practices. We heard about lack of exercise. Exercise is very important to have good sleep. Children who have a lot of screen time, and then just parental stress may end up with parents not being able to have good sleep practices. And I just want to emphasize, which is what we heard very well, that you need a multidisciplinary approach, because as you can imagine, looking at the behavioral, medical, and psychological problems, you're going to need people with different expertise. So these are just some examples of behavioral insomnia. The most common one, which people will be able to relate to in patients that they see, is called sleep onset association, which often is in very young children, where children are unable to fall asleep independently. And so when they wake up at night, when you saw that very first slide Dr. Okorie showed, where there's arousals at night that are normal, these children can't fall back asleep. Limit setting is another kind of behavioral insomnia, which is just exactly how the disorder is named, that children who have trouble dealing with limits set by parents at night. And then sleep timing are problems with the circadian clock. So children, usually teenagers, who prefer a delayed sleep phase, they like to go to bed much later and wake up much later. But you can also get a problem with advanced sleep phase, where children like to fall asleep very early and then wake up very early in the morning. So these are just some examples of behavioral insomnia. And these squares are different sizes on purpose. So this is how we evaluate sleep. So the biggest square is the history physical examination using questionnaires, because that is going to usually give you the answer about what is causing the insomnia. Sometimes we ask parents to use sleep diaries. Rarely, but more in a sleep clinic setting, we would use actigraphy, and you already heard about the reason to use polysomnography. This is just one sleep screening questionnaires for the clinicians who are participating today. It's called the BEARS. It was developed by Dr. Mindell, Dr. Owens in the States. It's just a nice screening questionnaire to remember when you're seeing parents and talking about their children who have insomnia, or when you're seeing teenagers. The BEARS, like the bear that you take to bed at night, is the acronym, just to remember to ask about bedtime problems, excessive daytime sleepiness. A is for awakenings during the night. R is for how regular the sleep is and the duration of sleep. And as you heard by Dr. Okorie, always remember about asking about S, which is snoring, or any evidence of sleep disorder breathing. And then there's all kinds of sleep diaries that you can find online, but sleep diaries are very useful when parents come to your office the first time and say their children are not sleeping well and you diagnose insomnia. If you send the parent home for a couple of weeks and get them to actually record when the child sleeps and is awake, and then they come back to your office, sometimes you can just look at the sleep diary and explain to the parent that this child's sleep is not consistent and regular, and that's the first step to resolving their insomnia. And as I said, actigraphy is more for the sleep clinic, but this is an objective way to measure sleep, looking at sleep patterns. So an actigraph is like a computerized motion detector, like we all have Fitbits, but it's just a little more sophisticated. And these black lines are where the person is moving at night. This blue shows where the person is not moving, and so this is sleep. And then we heard about polysomnography. So the treatment of insomnia. The good news is we know what works to treat insomnia. There's a lot of evidence for behavioral-based treatment, both for children who are typically developing, and there's emerging evidence that children with neurodevelopmental disorders will also respond to the behavioral treatments. The bad news is that less than 1% of children receive evidence-based treatment, and rather most are treated with medication. And probably this is similar for children with medical complexity. So, it's great that people are listening today, because we have to move towards behavioral-based treatment and save medication for children who don't respond with improved sleep to the behavioral changes. So it's going to be a very quick look at treatment. And I think you really heard clearly about addressing underlying conditions. So this is the first step. You heard from both Kate and Sarah that if Rowan, is having a lot of trouble with her skin, or if Kate is having, if Sarah is having trouble with spasticity, it's going to be really hard just to say sleep through the night. So you have to look at what the problems are that are causing the sleep disturbance. That's the first step. And, it could be any medical, mental health issue, could be enteral feedings, like a child who's fed through a G-tube at night. Any of these issues are going to be the first thing to address. The second thing is education. So often parents don't have or sometimes parents may need some knowledge about sleep. So for example, some people are owls, they like to stay up late, and some people are larks, they like to go to bed early. But both of these can be normal. You get into trouble if the parent is a lark and the child is an owl. So we need to look at the chronotype of the parent and the child. Sometimes parents think keeping up a child later will make them more sleepy, but it's actually the opposite. Children who are well rested will go to sleep more easily. Parents may think that arousals at night are not typical, but arousals at night are actually normal. The not typical part is when children can't self-soothe to go back to sleep. And then I think the fourth is really important, that some parents think that sleep problems are inevitable if there's a medical complexity in their child. And that's not true. We can still address this insomnia and help the children to sleep better. The third is implementing healthy sleep practices. So this is, I actually have a handout which you're going to receive that has what this mnemonic, the ABCs of sleeping, stand for. And you can think about this when you're seeing patients and evaluating their sleep practices. So it's just a mnemonic to remind you when you're talking about sleep with parents that children have to have age-appropriate sleep. They have to have bedtimes and nap times that are consistent. They have to have schedules and routines. You have to think about the location. If they have a safe space to sleep, you need to take electronics out of the bedroom. It's important to think about daytime activities too. When we think about insomnia, it's not just what happens at bedtime and at night, but it's also what happens during the day. So getting exercise during the day, not having caffeinated foods and beverages in the diet, making sure families have positive, relaxing time. It's not sort of saved until bedtime, helping children learn to fall asleep independently. And the ABCs of sleeping, the N and G means needs met during the day equals great sleep. So as I said, I have a handout with more information on this. And it's really important to take electronics out of the bedroom. That's number one. I've also provided you with a handout through Autism Speaks. They actually have a lot of information that you can use with children if they have autism. And this is just, again, parent information. So educating parents with sleep strategies for children with autism. And then specific behavioral interventions. Really, I cannot go into this because it's such a short talk, but I've given you some references in the handout. What I really want you to remember is that interventions that are behavioral will help children sleep better. So there's a lot of significant improvement through using behavioral interventions, and that often you don't need medications. Here's two references which you'll have that you can read more about behavioral interventions. And I just wanted to give you one example. Part of my research is developing eHEALTH interventions. The reason we're doing this is because, as I said a little 5 minutes ago, that only 1% of children get evidence-based interventions for insomnia. So with my colleague Penny Corkum at Dalhousie University in Nova Scotia, we developed a eHEALTH intervention that parents can access from their computer, from their laptop, from their phone, and all the things I just talked to you about, they can learn on their own with kind of a built-in coach and some built-in feedback. We're piloting it right now. We've finished a study for children with neurodevelopmental disabilities. Once it's peer-reviewed and published, we're hoping that it will be more available. And you can just see that there's little videos and homework for the parents through this intervention. So the last is medication. Again, this is a really quick run through medication. The important principles are that medication is best used after the behavioral treatment has been tried and in combination with behavioral therapy. If a family really cannot implement behavioral strategies, you can consider it at the beginning, but generally you want to do the behavioral strategies first. We need to use medication sparingly, and whenever possible, you can choose a medication that may help with a co-occurring condition, such as if a person has anxiety and insomnia, you can use a medication that may help both with the daytime anxiety, the anxiety at bedtime, and with sleep. And you definitely have to start at low doses. So I won't go into treatments, but there are a lot of treatments that are tried by clinicians, and really very little research. We don't really know about side effects, but we definitely try these medications when behavioral strategies don't work. Many children with neurodevelopmental problems are tried with melatonin, but it's important to remember that typically developing children with insomnia do not need supplemental melatonin, that they should respond to the behavioral strategies. But children with medical complexities, you may use melatonin. So in future directions, this is a slide from both Dr. Okorie and myself. We definitely need more research in thinking about how we combine medications, which medications to try with these behavioral strategies. I'm very excited about our eHEALTH intervention because I think we'll be able to use this in research, combining medications with eHEALTH and really be able to reach a lot of families. There are some new products. There's a product called Slenyto, S-L-E-N-Y-T-O, which is only available right now in Europe, which is a prolonged release melatonin that's very easily swallowable by a child because it's a very tiny wafer. And using this product with the behavioral interventions may also be something that's going to be very effective. People are really interested in CBD. We don't have a lot of research, but that's another area of research. And then Dr. Okorie, do you want me to just talk about yours? Okay, Dr. Okorie had added strategies to prevent and improve airway resistance. We need to improve exploration into desensitization protocols for PAP and more alternative therapies to PAP for children who have sensory sensitivities. So thank you very much for your attention. And I think our whole panel is here for questions. We're all available. Thank you.
Thank you so much, Dr. Weiss and Dr. Okorie. I really appreciate that. We have a couple of questions that were submitted early on. I do want to remind everyone that we will go an extra half hour. So you're welcome to submit questions in the Q&A. And this session is being recorded, so you will receive a recording of the full session. Real quick, before we move on to some of the questions that were submitted before we started, I want to just check to see if Kate or Sarah, do you all have anything, any thoughts or anything to add to the didactic portion of the presentation? We have lots of questions, so I could just dive in there. I'll go ahead. Let's see, first, and you, Dr. Weiss, you were just talking about melatonin. We have a couple questions about melatonin. Is it safe to give the non-prescribed melatonin to children who are under 3? And then another question about appropriate dosing and any long-term side effects. And are there other alternative supplements you might recommend?
Okay, we've got 4 questions in one.
Yes.
Okay, so the first is it safe under the age of 3? So as a primary care clinician, I would not give melatonin to a child under 3. I wouldn't give it to a typically developing child at any age, but in combination with a developmental pediatrician, neurologist, respirologist with expertise in sleep, there are occasions where we would use melatonin in a child with medical complexity under the age of 3. The dosing, so it's not like a dose like a medication. I don't want to give an exact amount, but it comes sort of from 1 to 10 milligrams. We know that if you take more than about 5 milligrams, you're probably just like metabolizing and excreting it in your urine. So the dosing is, we give like maybe 1 milligram to a small child, 2 milligrams to a middle school child, but I don't want to say specifically because you really need to talk to someone who knows about melatonin if you're going to use it. It's like, we just don't really have enough time for dosing. And the third question is, are there long-term side effects? There's some, but not very good evidence that there could be a change in pubertal onset. There could be a change in immune function, which is why we don't use it in typically developing children. And so when you use it in a child with a neurodevelopmental problem, knowing those possible side effects, you're discussing with the parent the risk benefit of using it. But in general, we don't see long-term side effects. And the last question was about other non-pharmacologic strategies. So there, people will use chamomile tea, warm milk because of the tryptophan in it. So all these strategies can be helpful, but they're not evidence-based.
Thank you. Can sleep apnea cause significant feeding challenges in a child with a complex medical condition?
I'll grab that one. I mean, sleep apnea can cause a whole lot of things. So I think can cause feeding issues, and please clarify if I'm not quite answering the question, but I think generally if a child is already just kind of struggling, if they're overtired, it can actually contribute to them having just more difficulty with doing, what they need to do during the day. It can actually increase your risk of reflux, can also contribute to that as well. So yeah, they can all be tied together.
Thank you. And there's another question about when a child has a medical diagnosis and a significant sleeping disorder, for example, Angelman syndrome, why might they sleep better when they co-sleep with parents?
Yeah, so it's a really good question because when I talk about independent sleeping, I'm not saying all children need to sleep independently. So if you look at around the whole world, more people sleep in a family bed with their parents, with siblings, than sleep alone. So when we talk about independent sleeping, improving sleep, it's when the co-sleeping is reactive. The parent would prefer the child in their own room, but they don't sleep through the night. And that's when we teach independent sleeping. So I don't know about this particular child with Angelman syndrome, but it wouldn't be uncommon for a child to sleep better with a family. And if that's the family preference, that's not a problem.
I just wanted to echo what Dr. Weiss said, because I actually often will first ask families, what is your preference? You know, I think we're talking outside of the neonatal age, obviously, where we worry about safety, but I'm the same way, where if families want to share a bed with their children, that's fine. I think generally a lot of parents don't, because it's harder for them to get a good night's sleep. So I just wanted to echo that, because I think oftentimes people assume all of us are against it.
Thank you for clarifying. I appreciate that. The next question is about children with autism. It says parents are exhausted and medications prescribed often don't work. So there's a question about the physiology behind this. Is there anything being worked on that may help our children and parents at this time?
Yeah, there's nothing like specifically in terms of the biology of autism. Like many people are looking at melatonin release in children with different disorders. There's a lot of basic science research on circadian clock genes, but nothing like that we know about children with autism. So most of the trials regarding sleep in autism relate to these behavioral interventions or behavioral interventions plus melatonin. There's a lot of research that shows that melatonin and behavioral interventions will improve sleep in children with autism.
Okay.
Yeah.
And then a question for Kate. How and when do you sleep, Kate?
It's hard. I think as a parent, when your kid is having a lot of difficulty with your sleep, like Maureen had said in the chat, you're not sleeping either. So it's this kind of cyclical thing. So I will say, sleep, like apps, like meditation apps are really helpful as a parent who has a kid who's dealing with difficulties and sleep. That's super helpful. And, speaking with somebody, therapy is super helpful because nighttime anxiety about the kind of medical issues your kid is going through is a real thing. And I feel like just as it's a thing for my daughter to her anxiety kind of can ramp up at night, it's a thing for parents too. So, try to get the sleep in wherever I can, but those types of things help as a parent, I feel like.
Yeah, thank you for sharing that. Another question is, do you have any preferred web links or other resources that could be used for educating families or for social media outreach? I know you're going to be receiving handouts from you, Dr. Weiss. Just want to give you all a chance to respond to that one.
Yeah, I can start. Definitely the National Sleep Foundation, which is an American organization, but it's free to the public, is a good resource. I'd like to say the Canadian Sleep Society. We don't have as many resources, but you can look at it. There are some really good baby web links. I know Carolyn, Dr. Okorie, there's one Jody Mindell started, but I don't remember what it's called. But
I don't remember the name off the top of my head too, but I think to Dr. Weiss's point, I think there are a few really trained evidence-based sleep physicians who do have a few resources out there. Jody Mindell is one, but I don't remember the name of hers, but I'll try to see if I can look it up in the background.
Yeah, or you can just Google Mindell, Mindell. So she started a very good website also. And then if you are looking after, or if you're a parent of a child with autism, Autism Speaks has a lot of resources about sleep.
Thank you so much. Another question asking you to comment on the contribution of lip and tongue ties to challenges with nocturnal nasal breathing.
Thank you for that question. I had the pleasure of, I was able to train with Christian Guilleminault, who I think is one of the first people who kind of described the association between tongue tie, or really the inability for the tongue to be able to move freely, and connection with orofacial structure and sleep apnea. And so I think there's a few things out in the literature now, but essentially the thought is if you have severe or significant tongue tie, it can affect kind of the positioning of your tongue. It doesn't tend to sit in the palate, in hard palate, which then can affect how the hard palate kind of develops. And with a narrow hard palate, you can have a narrow nasal base, and it can affect, again, how your orofacial bones connect. So it's a little bit of like kind of this, the tongue is a muscle that actually helps shape your airway. So if you have tongue tie or if you have nasal congestion, they kind of are thought to have similar contributions. Now, whether or not every child then needs a phoenectomy or kind of a clipping of that I think that remains to be seen. I think talking to your sleep specialist, talking to a knowledgeable ENT, I think is important, but there are some contributions that we can see. I don't know if Dr. Weiss has anything to add on that, but.
Nothing else.
So our next question is for prescription medications and other benign interventions that are effective for a given patient. Do you have a rule of thumb of how often clinicians should attempt to discontinue or wean patients off of medication to reassess non-medicated sleep?
Yeah, that's a pretty big question. But I think like the more general answer is that when we do use pharmacotherapy for insomnia, it's always for a limited time. And it's always with behavioral interventions. So the idea is that you might give the medication, just depends, each case by case will be different, 6 weeks, 2 months, whatever you've chosen as the time period, and then try to wean it off and see if the behavioral interventions will help the child to continue sleeping well. It doesn't always work. Sometimes children, especially with medical complexity, neurodevelopmental disabilities, require the medication for longer term, but it's always a good idea to try and see whether they really do continue to need it.
Our next question is about diphenhydramine as a sleep aid. Do you know of long-term negative side effects? And then someone also mentioned hydroxyzine and Atrax.
Yeah, so those are all like antihistamine type drugs. And I don't think there's any evidence, like research evidence on long-term side effects, but as a sleep clinician, it would be exactly the kind of drug that I had just spoken about, that if you're going to use it, particularly you might use that in a child with allergies or eczema for a very short term. You're not going to, I would not use that long-term. Dr. Okorie, do you have anything else to add about that?
The only thing to add is I was just trying to double check my work here, but I think there was a JAMA article a few years ago where they did see for really long-term use, and they're talking like decades of use of diphenhydramine on a regular basis, there was some association with some cognitive issues. So I think, just to Dr. Weiss's point, I think, these may be using it here and there in short term, but I don't think it's generally recommended for long-term use.
There's also a question about whether melatonin is addictive.
Yeah, that's a good question. So it's not addictive in the way we think like narcotics are addictive. Some drugs have an addictive potential. So it's not addictive in that way at all. So you can be on it and then stop it. You're not going to have like withdrawal from melatonin.
Mm-hmm. I'm wondering, for Kate and Sarah as well, in your experience, Sarah, when Kate, you had mentioned, having 6 specialists or more involved when Rowan was having sort of her last bout of trouble sleeping. And I was curious if palliative care was something that if you were introduced to palliative care through sleep, or if that seemed to be more helpful than other specialists, or or I guess just what you ended up doing, knowing that you couldn't, like, it was difficult to know who to kind of contact.
Yeah, I actually ended up contacting our pediatrician's office and just saying to them, like exasperated, kind of at the end of my rope, just saying, I don't know who to contact, but here's the problem. I don't even know how to explain this to you, but here's all the issues we're having. And I think you need to call everybody, is what I said to the pediatrician's office, like call these different specialists. And they were in the middle of organizing kind of a joint meeting between different specialists because I knew it was so intertwined that it wasn't just one person that I needed to speak to about these problems. So palliative care was one of those specialists that we thought we needed to speak with. And they actually were the ones who kind of solved the problem. So palliative care, we didn't start out with problems with sleep causing our need for palliative care, but palliative care has definitely improved Rowan's sleep by having somebody who specializes in palliative care. And they adjusted a medication because of course Rowan's issues, behavioral things can be an issue, and stress and anxiety, but then there's also physical problems that are happening, and pain is one of those things. So we adjusted her gabapentin dosage, and she's sleeping restfully again. And it was just really great that we have them available, palliative care. I don't know if that answers your question.
Yeah, it does. Just from talking to you, it seemed that palliative care was central. And I know that that's sometimes a referral we don't necessarily get, or, that you might have to work to find palliative care, but that they can be so helpful sometimes with this kind of thing. Let's see, we have another question. I have a 5-year-old with CP who has only ever fallen asleep without being with or on me since leaving the NICU. We're struggling with lots of night wakings and needing me to get him back to sleep. There's clearly sleep association problems. We're so desperate for more sleep that we're working with a sleep clinician and just tried private sleep consultant. But what I don't have much faith in is this: how is a nonverbal, non-ambulatory epileptic child supposed to learn how to fall asleep on his own when he hasn't done it his entire life?
Yeah, so first, before I answer that, somebody put in the chat the website to Dr. Mindell. It's www.babysleep.com. It's more about infant sleep, but it's a nice website. People are looking for information. Yeah, so that is a very complicated question, which I really can't address an individual, situation. I'm talking more broadly about the kinds of ways that we evaluate and treat sleep. But I would advise anybody who's participating, listening, that if your child has quite a significant problem, like it sounds like that, the parent is describing in her 5-year-old or his 5-year-old, that you should seek out a sleep specialist. If there isn't one, in your community, hopefully there would be somebody that could help you.
Yeah, I just want to add, I'm so sorry that you're struggling with this. And but I think, as Dr. Weiss said, I do think it's possible probably to improve sleep. I think there's different things that can be done, but I think it needs to be individualized and with someone who's truly trained in sleep to really help you with that. So I just want to give you some hope, but I think just really finding the right experts will be your best bet. And I think there's also a question in the chat that was kind of similar to someone who I think had a child who was in the NICU, and I think it's kind of a similar answer.
Mm-hmm.
And Kate, just to add, if this could be taken offline, if parents email you where they live, if they don't know who to go to, if hopefully they're in North America, either Dr. Okorie and I have a lot of contacts, we'd be happy to help find somebody.
Absolutely.
That'd be great. Yeah, I think it sort of brings up something that I kept thinking about in preparing for this seminar, which is when we talk about pediatric sleep disorders, and Kate mentioned this, we're talking about parents not sleeping as well. And I think you did too, Dr. Okorie. Like but that, I know just that can affect everything, right? I mean, just it's the same. It's still your health and your ability to work and function and not be depressed. And I just sort of throw that out there to everyone about, I don't know, Kate, you gave us good advice about meditation apps, and I just think it can be so just so incredibly difficult to not be sleeping and wanting to help your child sleep, but not having much success.
And I don't know, maybe Sarah, you want to elaborate, because you're very clear about, people asking you about your sleep once and having trouble finding somebody to help you or even talk about your sleep.
Yeah, and I think it was I might have just like walked into the office and looked really tired or didn't look like myself, and that's why it came up. But I know other times where I have trouble sleeping is either while I'm hospitalized or coming out of a hospitalization, because they wake you up every 4 hours for something. Somebody's coming in I don't know how they expect people to sleep in hospitals. It's very noisy in there. So and this is a big ask, I know it is because I do it myself. If you're going in for hospitalization, see what the schedule is for like, when are they going to come draw labs? When are they? So like, I know like residents around at 5 o'clock. So I know they're going to wake me up at 5 o'clock. So I kind of try and build in an app, and I'll actually tell like my nurse, like, look, if I'm asleep, don't wake me up. Can this wait like another hour? Or try and condense things. So see if you can work with whoever might be in the hospital with you bedside and say like, look, this is what our schedule is at home. Can you kind of work with us? I know some things can't be moved around, but yeah, that does make a difference. But that I've definitely found you have to be more proactive from the patient and family side and kind of be more assertive than most people might typically be, in an everyday interaction. But I think with this crowd, you're I would assume you're more used to being assertive in that way, but yeah. So that's my advice. I don't know, I always say it's kind of like sleep training yourself for an inpatient visit, which I feel like you shouldn't have to do that, but if it makes everything better all around and it helps you heal faster, and maybe you can get out of the hospital one day sooner and sleep in your own bed, I'm all for that.
Yeah.
There are actually studies, and I'm sure Dr. Weiss is maybe going to say this, but that we do realize that we need to improve sleep in the hospital. And so I think I just want to add that, yes, advocate for yourself. And I know, again, parents of kids with complex issues are such great advocates. So I think it's okay to remind the team, that maybe are there things that can we not do the vitals at midnight? Can we think about a lab check? I actually think that is all very good. And I think a lot of hospitals are starting to think of ways to improve sleep. But I think we're still in the infancy of it.
Thank you. And Dr. Julie Hauer is saying that for parents struggling with the sleep, that sometimes palliative care teams can also be a resource for challenging symptoms, including sleep. So that's just another sort of plug for palliative care and asking for a referral to palliative care, because they can be so helpful. Let's see. And then we have a question also about that it's difficult to know, what specialist to go to if you see a pulmonologist and they give a CPAP and then it just doesn't work. And I think that the palliative care is kind of speaking to that issue as well. Another question is, any specific challenges that may happen to children who are born blind and parents say their day and night are mixed up?
Yeah, so one of the, we call it a Zeitgeber. That's like a clue to keep your circadian clock on a 24-hour. And one of the Zeitgebers is the release of melatonin. The release of melatonin is directly related to light getting through your eye to your brain to tell that the brain it's time to release it when it's dark. So unfortunately, when children are blind, sometimes they don't have that circadian reminder, and they don't have a regular release of melatonin. And so that is a good reason to try melatonin. And that might not be the only reason, because I also talked about some of the other Zeitgebers for the circadian clock to keep you on a 24-hour cycle are social Zeitgebers. So like getting out in the morning and playing in the playground and having exercise also helps you to sleep at night. So, you know, there are other things that you want to try and build into a child's life, exercise, that might also help sleep, that you may need to be like more creative in how you're going to develop that in your child's daytime activities.
And just to add, I think there was something, I'm looking through the chat, I think someone had mentioned patients who have trouble with exercising. And just to clarify, it's not always, it doesn't necessarily go out and on a run or for a swim, but it could just be getting outside, even just if they're in a wheelchair, like, you know, rolling them in a wheelchair through a park, getting fresh air. So it's even just trying to make a difference of having some activity during the day that can look, you know, very different for each child, and just trying to distinguish daytime from nighttime. So even for kids who are blind, it's like, even in terms of other stimuli, whether it's tactile or auditory, you're just trying to make maybe make a distinction to help them have a routine.
Yeah, that makes a lot of sense. I mean, one of the things I think we're learning more and more about is like even the most subtle movements can kind of count as exercise. And I'm also struck, Sarah, by what you said about how, you know, as an adolescent, you might have gone for whatever was easiest. And it wasn't until you were a little bit older that it started to make sense that exercise, that sleep was sort of part of just helping you have a better day, or, you know, perform better as an athlete. But I think for children who maybe we can you know, sort of work with on that level, I think that they can be motivated in all different ways about how sleep can help them have a better day the next day. When we just have a comment that from a support coordinator who supports a lot of kids with CP who are nonverbal and non-ambulatory, that they're treated mostly with medications. And so I think we've kind of been speaking a lot to that, that there are so many other options. I wonder, Dr. Weiss, your eHEALTH, the better nights, better days, I'm sure I'm not alone in thinking like, oh, I've got to get some access to that. Can you tell us how we can access, or is it yet available? I'm sorry if I missed that.
No, you didn't miss it. So we have two Better Nights, Better Days interventions. One is for typically developing children. One is for children with neurodevelopmental disorders. They're both we've completed the research to show that they're effective. And there is a plan to make them available on a sliding scale to families, first in Canada, but we haven't yet got that plan finalized. But if people look at the website, you can just Google Better Nights, Better Days or Better Nights, Better Days NDD. You can keep in touch with that, looking at the website and seeing when it'll be available, but we don't have an American partner yet.
Oh, we got to figure that one out. Yes. Yeah. There you go, Dr. Okorie. All of our wheels are turning now.
Yeah.
The link has been put in the chat.
Okay. It's actually the first version for typically developing children is also available in French. And we have had some interest from people in other countries to translate it and make it available in other languages. And I want to say we're not the only ones who have an eHealth intervention. There are other sleep researchers that are also developing eHealth interventions for children. But once these interventions are available, it's going to be the first step in step care. Not all families are going to be able to improve their child's sleep with eHealth, but definitely some people will, and we hope a lot of people will.
I appreciate that. Well, we're nearing the end of our time. I want to just give a moment for last thoughts. Probably each have a minute to sort of, I don't know, anything that stands out to you or anything you'd like to share. Sarah, could I ask you to go first?
Yeah, if you're having, well, I would say if your child is having trouble sleeping, but I think we've all learned today that if the child's having trouble sleeping, everybody's having trouble sleeping. Just find somebody you can partner with. It doesn't necessarily have to be, a high level person. There's stuff online. You can try different things. It's a trial and error thing. Like I said earlier, I went to, I think it was like the sports section of, I think Barnes and Noble, and they have now chapters in sports psychology books on sleep. So you can even start there. So, I mean, you can partner with a person, you can partner with a book, you can partner with shit, but find some kind of partnership and somebody that you can bounce ideas off of.
Thank you so much, Sarah. Kate.
Yeah, I just wanted to also add, I just thought about this. I would just ask clinicians to ask their patients' families describe what your child's sleep looks like. Because I think as parents, we're so used to sometimes, and especially kids with medical complexity, we're used to things kind of being bad is one way to explain it. So you get kind of used to that. So I think that that's an opportunity for clinicians to understand what's going on with families who may not kind of understand or really think that maybe they have a problem, like their child's having a problem with sleep, but then you ask them, like, how's your child sleeping? And the parent might say, oh, well, they wake up like 15 times during the night. And, I'm probably not sleeping very well. But as parents, I think we get used to things and then it doesn't seem as unusual to us and we don't think to ask about it. So asking families about sleep is important.
That's great advice. I like that. Yeah, and really asking what exactly it looks like. Yeah, I like that. Dr. Weiss.
Yeah, so I think I would just leave you with the idea that we can make a difference. We can help people sleep better without medication, although there is a role for medication. And I just want to reiterate, Kate said it so well. If you think about not mine, because it was developed at Dalhousie, the ABCs of sleeping. And if you're a clinician and you're talking to families and you want to ask about their sleep, if you have that in front of you, which we're going to have as a handout, and go through each of those parts of sleep that are important and the daytime activities, that you're going to be able to start to understand why the child that you're looking after isn't sleeping well, and start to think about how to improve their sleep. So definitely sleep can be improved. I'll leave you with that.
I guess I just want to, for my, I think, parting statements is I agree. I think, having, knowing that kids are dynamic and it might take a little bit of some creativity, but that's where the individualization comes through. But it might seem like a lot of us are saying, trying to avoid medications. We definitely use medications in our practice. I know Dr. Weiss and I both do, but we know in the long term, adding these behavioral things in addition to treating underlying conditions is really one of the most effective long-term strategies. So we're optimists, or we wouldn't be doing this. So we know that it can work and we've seen it work. So thank you for everyone's attention. Thank
you all so much. I'm so honored to get to moderate this panel today. And I want to thank everyone who participated and joined us. A reminder to please complete the evaluation after today's seminar. You'll need to complete it by April 25th to claim the CME credits. You'll receive more information on how to do that by email. Again, apologize for the confusion getting logged on. Thank you all so much for attending. And again, just a huge thank you to SickKids, the Lucille Packard Foundation for Children's Health, and our incredible panel today. Thank you all so much for what you shared. We really appreciate it.